Good morning, everyone, and good afternoon to those on EST time. I wanted to welcome everybody to our second annual Within Summit. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I'd like to introduce you to Dr. Caitlin Shepard. Dr. Caitlin Shepard is the Clinical Research Director here at Within Health. She is also a licensed psychologist and a research affiliate. She has been in the field for over a decade and has a lot of experience within the eating disorder field. She earned her MS and PhD in counseling psychology and completed advanced clinical and research training in the eating disorders program. Dr. Shepard will be presenting on the topic of optimizing eating disorder treatment, the case for measurement-based care. Before we do hop in, I have some general housekeeping things to go over in regards to the CEU credits. Evaluations will be sent to the email that you use for registering for this presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CE Go dashboard for all things CE related. A video of the presentation will also be made available right after the presentation. However, you will not get credit for just watching the video. You have to attend live in order to receive your CE credit. To access the video, if you would like to see it later on, please utilize your CE Go dashboard for that. If you have any technological issues and need to change devices during the presentation, you will, however, receive credit. I will provide my email as well as Jamie Singletary's email in the chat. If anything does arise, feel free to email both of us with any of those tech issues. For any other questions or concerns regarding obtaining CE credit, please feel free to either email me, like I mentioned, email Jamie, or reach out to CE Go themselves. I will provide their contact information as well in the chat, and they can work through any tech issues as well. I will now pass things over to Dr. Shepard, and welcome and thank you for presenting today.
Thank you so much, Ashley, for that introduction and for all of that really important information. As Ashley said, I'm Dr. Caitlin Shepard, and I'm the Clinical Research Director here at Within, and I'm delighted to be here to talk to you all today about implementing measurement-based care in eating disorder treatment settings. So Within is really committed to using data to inform our treatment and improve clinical outcomes. And so we've instituted a measurement-based care initiative that I'm co-leading in collaboration with our exceptional clinical leadership to ensure that we are keeping up to date on best practices in the field. And also we're working on expanding and refining our approach as our programming grows and evolves. So given my background, as was mentioned, as both a clinician and a researcher, I have a lot of experience in the use of standardized assessment tools. I believe strongly in leveraging data to optimize care, and I plan to share that passion and expertise with you all today. But I do want to say that I'm approaching this talk with more of a focus on joining you all in the challenging work of navigating real-world implementation challenges, since in many ways I'm right there with you all if this is something that you are, starting to try to figure out in your own practice or program as well. And I don't have all the answers as far as how to implement these systems perfectly. Rather, my goal for today is to really try to underscore the need for more eating disorder treatment providers to be using and programs to be adopting a true measurement-based care model, and also to bring to light some of the important points to consider when pursuing your own measurement-based care implementation or expansion initiative, wherever you may be in that process. So with that in mind, you'll see our agenda here. I'll wrap up with this introduction and then move on to provide a brief overview of measurement-based care, or MBC, as I'll call it, highlighting the rationale for using this particular model. We'll then get into implementation of MBC, including barriers or challenges and facilitators, as well as specific recommendations for eating disorder treatment settings in particular. And then I'll introduce a brief brainstorming exercise to help you all identify next steps for incorporating or potentially expanding MBC in your own practice or program. And time pending, we'll see how we're doing, potentially invite folks to share their thoughts on this if you so desire. And finally, I'll try to leave some time at the end for questions and answer. So as we cover these different topic areas, I'm going to focus on hopefully helping you to meet these outlined learning objectives so that by the end of the talk, you'll be able to One, distinguish MBC from other data collection approaches by describing the three components of the model. Also be able to articulate the rationale for MBC by explaining one primary benefit across each of three levels, so patient, provider, and organization. Summarize three key findings from research on MBC in mental health care. Identify three barriers and three facilitators of MBC implementation initiatives. And then state three major categories of measures relevant to eating disorder treatment settings and two important considerations for selecting or using measures with consideration to diverse populations. So that's a lot, I know. So let's go ahead and dive right into the overview of and rationale for MBC. So it's always difficult planning a talk you don't without knowing kind of who the audience will be. So I understand that we likely have folks in the audience today with varying levels of experience with and understanding of MBC. So my goal today is to really just kind of make sure that we're all on the same page. So for those that are already really familiar with and practicing MBC, this may feel more basic and rudimentary. But for those, for whom this is less familiar, hopefully this will kind of get people sort of up to speed. So with that, I want to start with clarifying a common misconception about MBC. Again, for those who may be less familiar with what this term actually means. So I've heard this, for some time and continue to hear this perception that some people have that measurement-based care, or MBC, is kind of a cookbook medicine approach, where you're just sort of following a recipe. It reduces patients to just a number or a set of numbers, and that it doesn't really allow for any sort of flexibility, clinical judgment, or individual patient differences. My hope is that if you too hold this view, that I'll be able to, help show you otherwise today. One of the things that I personally love about MBC is that it is truly a blend of science and art. So just a sort of quick personal anecdote. Prior to pursuing a career in clinical psychology, I was pursuing a career as a professional ballet dancer. And I see a lot of parallels between these two fields in terms of that blending of science and art. And that integration is in large part what ultimately drew me to this work that I do now. So as a researcher, in particular, one with a background in primarily quantitative methods and statistics, it's probably no surprise that I really love science. I love numbers. I love data. If you give me a spreadsheet with formulas, I'm, happy as a clam to play around with that all day long. But in both ballet and clinical psychology or other similar fields, there's this delicate balance between science and artistry that I also truly love and enjoy. So in ballet, I think about this level of precision needed to execute the steps properly, yet it's really the artistry, the emotional expression, each dancer's interpretation that ultimately creates a performance that resonates with the audience. And I see that similarly in clinical psychology and other similar fields, that the data gathered via, in this case, standardized assessment tools, it still has to be interpreted and understood within the context of each individual's circumstances and experiences. And so there's kind of that artistic creative piece to it as well. So I've heard some start to use the term measurement informed rather than based care, which I like. I haven't seen it catch on completely yet, but I think given this intersection, that may be a more sort of accurate description of this model that I'll go into a little bit more detail about now. So now we know, if you didn't before, that measurement-based care is not this cookbook approach. It's not just focused on numbers, kind of in a vacuum with nothing else. So then what is MBC? So MBC, you'll see a definition here. It's the use of systematic and routine patient-reported outcome measures throughout care as a core element of evidence-based practice, which is a concept I'll come back to if that's also a term that's less familiar. The purpose of the data collected within an MBC model is to track patient progress, inform treatment decisions, and engage patients in their own care. So it's first and foremost about individual patient care. And this is something that, I continue to see kind of misconceptions about or misuses of the term. So sometimes MBC is conflated with other forms of routine outcomes monitoring focused on things like quality improvement or program evaluation, which are, of course, also essential, important activities in mental health care and eating disorder treatment. And the data collected from MBC initiatives and programs can certainly be aggregated and used for these other purposes. But MBC is a distinct approach that is really focused on the individual level of care. So a true MBC model promotes a data-driven and patient-centered approach to healthcare. So on the last slide, I mentioned that MBC is implemented as a core element of evidence-based practice, or EBP. This is another term or concept that is often used in different ways. So I want to take a moment to clarify what I mean here when I'm using this term. So EBP in this context goes beyond what we typically think of as evidence-based treatments, or EBTs. It incorporates the best available research evidence, which may include, but is not limited to, randomized controlled trials, or RCTs. We just love our acronyms here. However, as you can see here, EBP also integrates patient factors, so patient characteristics, values, circumstances, even preferences, acknowledging that these factors matter as well and need to be considered alongside what the research shows. And finally, clinical judgment is also a vital part of this model. So this is akin to that artistic or creative piece that we touched on earlier. So clinical expertise is required to figure out how to integrate these other two elements. So to bring the research and the patient factors together to ultimately make informed and individualized treatment decisions. So sometimes I see EBP used synonymously with specific types of evidence-based treatments, and here we're talking about it more broadly. And EBP is considered essential for providing optimal care for eating disorders and other mental health concerns. In that vein, ongoing monitoring of patient progress, adjustment of treatment, and consideration of individual differences are all crucial parts of EBP that can be facilitated by MBC. So you can see here that we're starting to kind of build this case for measurement-based care as a means of optimizing eating disorder treatment. So how do we actually do that? So I want to take a little bit of time to actually talk about the MBC model. There are some different frameworks out there, but within, we've adopted the three-part collect, share, act model of MBC. This was developed by the Veterans Health Administration, MBC and Mental Health Initiative, and then further detailed by Dr. Resnick and Dr. Barber from the Yale Measurement-Based Care Collaborative. These are, just side note, both truly amazing resources that, if this is something that you want to learn even more about, they have a wealth of resources available to kind of talk through all these pieces in even more depth. So I will go into a little bit more detail about each of these components in a moment, but the piece that I really want to highlight here is that this approach, this measurement-based care model, is all about fostering collaborative relationships between the clinical team and patients. So again, it's not at all about just reducing people to numbers or anything like that. It's really about having that collaboration. And you can see that collaboration from the very beginning with the collect stage. So this is not something, completing these measures, this is not just occurring behind the scenes amongst the clinical team members, reviewing data, or something that is happening to patients, where they're just being required to complete something for some other purpose. They are intended to be active participants in this process from the outset. And you'll see also here the routine and repeated administration highlighted that I mentioned in the definition of MBC previously. So within an MBC model, these measures are collected as part of standard care at specified time points. So it's not something that's just done sporadically or on an as needed basis where we, administer a particular measure to somebody. It's an expected and core part of treatment. For this share stage, you'll see that the emphasis is on sharing and discussing with the patient. Again, not just amongst clinical team members separately, but really engaging the patient in this process. And finally, for the ACT stage, you'll again see that here it talks about treatment changes and recommendations. These are not things that are just decided and dictated to patients, but rather patients are engaged in this process as a key member of their team. So again, it's really about fostering this collaboration. So just to provide a little bit more information about each of these steps, and again, there's so much more. We could easily spend an entire training on the actual clinical practice of employing this model. But in line with our goal for today, I want to just briefly describe each component. So again, we have a shared understanding, for implementation kind of planning purposes. So for the collect stage, you'll again see how patients are engaged as collaborators in this MBC model, and that there's really a strong emphasis on transparency. So we start with describing the MBC process to patients, including things like how often the measures will be repeated so that this is something, expected, they can anticipate. Who will have access to the information? This is a question that comes up, sometimes in the context of concerns about, data privacy and security, but also people often want to know, who else on their team, if you're the primary therapist, for example, who's having this discussion, they want to know who else on the team could have access to this information. If it's an adolescent or, a young adult that has maybe parents or caregivers or others involved in treatment, they may want to know, if those individuals will have access to the information. So describing that process and what that will look like. And of course, this may differ by program, but the conversations that I'm outlining across these components here are most often or will likely be between a primary therapist or clinician and the patient, or at least someone with whom the patient is going to work very closely and have opportunity to really continue to build a relationship and, discuss these measures and their scores and interpretation throughout treatment. Next is discussing the impact of MBC on care. So this would be things like talking about how the data are going to be used to help create individualized goals, assess progress over time, and modify treatment plans as needed. And finally, at this stage, it's important to explain why each measure was selected and how it's relevant to the patient's treatment. And this might differ again, depending on if, your program has kind of a standard battery of measures that everyone receives. Then it may be talking about, why we use these measures in our program, why we think that these are relevant to the patients that we serve in general. But also where possible, it's helpful to engage patients in that selection process and consider adding additional measures that you have collectively, agreed upon being relevant for this particular person in their case. So again, engaging them as a part of this treatment team. And it's really important to normalize this process, again, as a core part of treatment from the beginning and convey the message that these measures are for patients to support their treatment. So often, I think patients have gotten the message, perhaps coming from other treatment programs where they weren't using an MBC model, but they've gotten this message that these kinds of outcome measures and this data are needed for other purposes. So, well, we need this for, insurance purposes or for accreditation or for research or, any number of other things, instead of really having it be about them. Like, this is for you, this is to, really support and assist your treatment. And so that's likely to contribute to less reliable and valid information being obtained when people are not really feeling that kind of ownership and personalization. To go into a little bit more depth about the next step. So now you have your data, you've collected it. So building off of that point I was just making, there needs to be a clear process then for sharing that information with patients. So again, they can really see how the data are being used to help them. So the first step here is having the clinicians report or review the data with the patient and explain what they might mean, based on the properties of that measure, what this measure is actually assessing. For instance, there might be cutoffs, norms, or criterion levels that can help the patient better understand, their scores and kind of, where they are perhaps relative to others, or where they are now compared to where they had been previously. The next point, I will say, if you remember nothing else from this talk, I hope that you remember this next piece. I think it's one of the most important parts of the MBC model that, again, with all these kind of misconceptions and sort of misuses of the term, gets missed. The explore step, the clinician needs to explore with the patient how these scores compare to the patient's own subjective experience or other sources of data, and then talk about any discrepancies. So within an MBC model, the data that are obtained from these patient-reported outcome measures are not meant to be viewed as, the sole source of truth, or even a stronger or more important source of information. Again, this goes back to the idea of evidence-based practice and that approach, and kind of pulling in, patient factors, clinical expertise. Really, this is meant to be looked at as, okay, here's one piece of information. How does this fit with your perception? How does this fit with, what we're seeing in, your group experiences? How does this fit with, what your parents are saying? So it's really combining all this information together and then kind of thinking about what this might mean. So that's really, I think, very important to not miss that step, that's really central to this model. And I think, again, really conveys to patients the idea that this is not just about reducing you to a number. This is just a piece of data, and we want to think about how it fits with everything else, or doesn't fit in some cases. Sometimes these explorations actually lead to opportunities for education. There may be discrepancies, for example, and sometimes what that reveals is that people may have had some misunderstandings about the questions. These measures are far from perfect, so sometimes people will interpret a question in a way that it's not intended, and so then you can clarify that. It may also be that having this kind of exploration, you might want to educate people about what this measure does and does not assess. So maybe they're, thinking, well, I'm feeling much more depressed, and, that yet this measure is suggesting that I've gotten better. Well, maybe this particular measure that you're using is only tapping into certain types of depressive symptoms. And, that's not, as specific to the kinds of symptoms that you're experiencing. So clarifying misunderstandings or misinterpretations may help to then resolve some of those discrepancies. And then lastly, the ACT stage. So now that you've had this chance to review the information and discuss and talk about it, lastly, we want to, as the name suggests, act on the information that has been gathered. So after having reviewed the results, the first step here is to appraise what the results mean for this patient. So to kind of, have this sense of, in general, do they seem to be getting better, getting worse, showing no change? It's, of course, hard to kind of really reduce things down to that, but getting a general sense of what does this mean in terms of their treatment trajectory, and keeping in mind the bigger picture that you just discussed. And then next, to use that information to brainstorm with the patient. So again, using their scores along with their impression, your clinical judgment, any other relevant information to generate ideas of treatment adjustments if appropriate. And then based on that, finally choosing a plan of action. So engaging in a conversation with the patient to weigh options and collaboratively, make decisions about how we can use this information we collected to, really fine tune your treatment or try something different if, that may be beneficial. And one of the things that I really like about laying out the model in this way and kind of talking about these steps is that I think it usually helps make clear for clinicians who maybe are unfamiliar with MBC or are just in general less familiar with kind of quantitative, standardized assessment-based approaches, maybe don't feel like they are more sort of numerically inclined people. I think it makes more clear that people already have the skills necessary to practice MBC. Beyond potentially needing to become more familiar with some specific measurement tools. And another side note here, I am in full favor of having, cheat sheets and things like that to help with that piece, especially if you are building out a large library of measures. I don't have, everything memorized as far as every single, scale, subscale, cutoff, norm, value, et cetera. So having those kinds of resources to be able to refer to, I think is totally accepted and, often necessary. So beyond maybe needing to kind of become a little bit more familiar with some of these tools, most clinicians are already engaging in similar kinds of interactions with patients, right? Talking about different pieces of information and data that maybe seem discrepant and don't seem to go together. And how do we make sense of that? And where do we go from there? So it's a lot of what people are already doing. It's just, adding in another piece of information potentially. All right. So we've talked about what MBC is. So now that we have a shared understanding of the basics of it, I do want to talk a little bit more about why. Why would we want to implement this kind of approach? There is research that shows that MBC is associated with a number of benefits, including improved patient outcomes, so symptom reduction, improved functioning, as well as reduced rates of non-response, lower treatment dropout rates. And these things should make sense since when we think about MBC, it allows for closer monitoring potentially of outcomes, enables making timely, personalized, targeted treatment modifications. It engages people more in their own treatment, and so they may be more likely to, adhere or persist in treatment. Research has also shown an association with increased patient satisfaction. And again, perhaps due to that collaborative relationship and involvement that we've discussed. And the benefits of MBC can be seen across levels, across patient, provider, and organizational levels. In terms of direct benefits for patients, utilizing MBC can help ensure respect for their rights, again, by actively engaging them in treatment decisions. It can facilitate the offering of individualized, tailored care. And in general, encourages, again, that engagement and empowerment throughout treatment. So really giving patients a voice and a say in their treatment, which we know can be especially important when working with eating disorder populations. The benefits of MBC go beyond the patient level, though. Getting providers on board with MBC can at times be challenging, as we'll discuss a little bit more when we get into barriers and challenges, especially if this is perceived as something that is just going to be added to their workload with little direct benefit to them. However, there can be a number of benefits for providers if MBC is really, implemented thoughtfully. So for providers, enhancement of the therapeutic alliance, which has actually been supported by research studies. But again, depending on people's conceptualizations of MBC and sort of beliefs about it, they may not immediately see this as a potential benefit. So they may think that, in fact, it would have a negative impact on the therapeutic alliance if you're having to sort of be forced to track people down in complete measures and get so focused on numbers. MBC can also help providers clarify patient diagnoses, facilitate case conceptualization and treatment planning in ways that may ultimately streamline processes and enhance efficiency, again, without imposing additional burdens if this is done in a thoughtful manner. And finally, there are benefits to organizations for implementing MBC beyond, of course, having more satisfied patients and providers, which is a benefit. That's certainly a plus. But beyond that, there are benefits, as I kind of alluded to previously, such as having data available to support quality improvement efforts, identify programming needs and shape services, and show value to stakeholders. So the sort of aggregating that data and then using it for other purposes. So I've started alluding to some of this already, but I do want to spend some time now looking at practical issues related to actually implementing MBC in mental health and specifically eating disorder treatment settings, and go into that piece in a little bit more depth. So I want to start this section with a statistic, comes from a review paper, and they found that, despite all of the aforementioned benefits and potential positive outcomes, less than 20% of behavioral health providers actually use MBC in their, practice or in their treatment program. So that's, not a very large number. But listed here are a number of common barriers that have been derived from research, which might in part account for these findings. So we'll try to reframe these not so much as total barriers per se, but rather challenges that may need to be considered and can be addressed when planning for MBC implementation. So in terms of patient-related barriers, time constraints is a big one. So thinking about how much time it will take patients to complete these measures, how much time will they need to get through, your full battery if you have more than one measure, and when will they have time to do so? So sort of when in their treatment, stay or in treatment process, will they actually be able to do this? Is it going to be like on their own time? Is it going to be when they come in for, a session? What will that actually look like? Patients may also have concerns about the impact of their scores on their treatment, such as negatively affecting their relationships with their providers. So there may be hesitancy around completing these measures, especially if, maybe folks are struggling. They may not want to complete them truthfully, honestly, because they might be concerned about how this might impact the work that they're doing, not wanting to, offend their clinician. And so those kinds of concerns might come up. And also, I've mentioned this previously, privacy and confidentiality concerns, who's going to have access to this information? Where is it going to go? Especially depending on how it's being collected, is it being done online or something like that? People want to know what's happening with that data. In addition, depending on the population you're serving, some patients might present with symptoms, cognitive impairments, other disabilities that could interfere with their ability to complete patient-reported outcome measures like this, especially in certain formats. So that may be something that needs to be considered, again, depending on your population. As I mentioned previously, administrative burden for providers, so concerns about the time it will take, the effort, potentially the cost or the money lost by having to do potentially additional paperwork or something like that, can be a challenge to MBC implementation. And then also, I was kind of alluding to this previously too, some negative beliefs and attitudes about MBC. So people feeling like it's taking away their freedom to use clinical judgment, or that it's detracting from other work that they're doing or from the therapeutic relationship. And providers may also have concerns about use, but in different ways. Another issue that frequently comes up in the implementation literature is provider concerns about the use of the information for performance evaluation purposes. So people being concerned that, if their patients are completing these measures and they're showing that they are not improving in a certain way, that could then be used, punitively towards them. And so there are concerns that might come up around that. And then organization factors that might serve as barriers include things like resources, always a concern, right? Having the personnel needed, having whatever sorts of IT resources you might need, having training, having access, an ability to administer some of these measures. Staffing issues and concerns can come up. So concerns about things like turnover, if you have certain folks that are kind of leading the charge with the MBC initiative, and then those folks leave, getting other people up to speed, leadership support. So as with many things, it's really important with these kinds of implementations that there's, support and understanding from above. And so that can be a potential challenge. And this is a really big one, overall readiness in terms of organizational norms, culture, and climate around MBC. This is one that I know comes up a lot in the literature. It's certainly one that I've seen as well. Depending on, where people are coming from and kind of what the culture was around, assessment tools and data in general. It can be really challenging to have a culture shift towards really embracing MBC, thinking about it as this collaborative, kind of model, rather than sort of thinking about, again, as I mentioned before, oh, this data is for research or for some other, kind of purpose. And so that shift can be really difficult to make. On the upside, there are things that can be done to address these barriers, overcome challenges, and ultimately facilitate MBC implementation. There's unfortunately relatively little research on facilitators. There's certainly more on, barriers and challenges that may come up. The literature that does exist does suggest that training for providers, especially that includes active learning components. So, engaging people in difficult discussions, doing case presentations, offering opportunities for people to observe or shadow other providers, and then giving people chances to actually practice different parts of the MBC model and procedures, that these are really beneficial, as well as with so many things, just simply gaining the experience can be beneficial. And also having ongoing consultation and support. Again, as with many things in this field, just having one single standalone training is not enough. Again, I feel like every single thing I'm going through could be its own training. And so this is something that really needs to be ongoing, need to likely have multiple training sessions, need to have opportunities for providers to have ongoing consultation, supervision, and support, so that they can, talk about what's working, what's not, be able to troubleshoot, et cetera. And I mentioned this a little bit already. There's also evidence that making sure that leadership is really trained for implementation, that's really essential, that they're able to support providers. So making sure that, from the top down, people have a really clear understanding of what MBC is and what it isn't, and, the benefits and, the kind of purpose behind it. That's really key. There's a really interesting study. I have references at the end of the slides. There's an interesting study listed on there by Holliday and colleagues, and it looks at what characteristics of clinician-patient interactions contribute to MBC being perceived as valuable. So they're looking at, in these dyads, what characteristics of these interactions ultimately resulted in both the clinicians and the patients seeing this as a valuable pursuit. And one of the findings that came out of this study is that fidelity to the model was associated with high value across both parties. So specifically providing, as I said before, a clear, repeated, strong rationale, actually discussing results after every administration. So patients aren't feeling like, I completed this and then what happened to it. Actively engaging patients in the process. And then connecting scores to specific treatment recommendations. So really having that integration with treatment planning. This same study also found, this is one of my favorite findings, because I'm definitely a data graph visual person. They found that using graphs to visualize progress and guide discussions was beneficial. Patients seemed to demonstrate a stronger understanding of MBC and, of their scores and progress when visualizations, when graphs were included. And there have actually been several studies to support that, but this is one in particular where they found that. In addition to these findings coming from research studies, there are also a number of emerging best practices and recommendations for addressing some of those aforementioned challenges, including things like developing or adopting streamlined systems that are technology enabled when possible, and compliant, of course. There are a variety of platforms available that essentially do all of the work for you in this regard, from sending out reminders to patients to complete their measures, to automatically scoring and graphing data, securely storing the data, integrating it with your EHR if you have one. Of course, these platforms may not be a feasible option for everyone. So this streamlining may instead refer to, coming up with your own internal processes for accomplishing these tasks. So as simple as, for instance, having a spreadsheet template that you use where you can input scores and, quickly track and graph progress. Having systems may also include having processes in place, or at least having the flexibility to make modifications when necessary, depending on specific circumstances. So for instance, I mentioned cases where people might not be able to complete the measures in a certain format. We've had cases at Within where patients couldn't complete measures using our online or app-based platform due to things like technical issues or difficulties, health-related issues like a TBI. And so we had to, be creative, bring in that artistic piece and figure out how to shift and accommodate. So things like sending out a PDF to be printed, scanned, and sent back, and then inputting that information, having folks complete measures as an interview format instead. So having that kind of flexibility built in can really help with implementation, so you're not caught off guard. Another recommendation that comes up in the literature is to focus on the people. And by that, I mean identifying what they call local champions, which are providers who actively embrace and promote MBC and can encourage others. One of the things that has been happening at Within is that we have some folks who are local champions and who are really embracing and utilizing this model, and are then presenting some of their cases to other members of the clinical staff to really illustrate what this looks like, certainly the challenges and, issues that can come up, and also the, sort of positives that can come along with it, and doing, that as part of training as well, kind of that ongoing training piece. Also building teams and collaboratives, so that can help with issues like staff turnover. Again, so as I said before, you have, if you have people who are leaving the organization, you haven't all of a sudden lost, everyone who's trained in MBC, really kind of thinking about having teams for that kind of situation. And then this last one can be a bit trickier, but there are some calls to consider how to incentivize MBC. Sometimes you'll hear this talked about on a broader scale. So this may refer to incentives from third-party payers for engaging in MBC and achieving certain outcomes. So such as is the case with the value-based care model. Here, though, what I'm referring to is more on the provider and organizational level. So again, when implemented in a thoughtful manner, incentivizing response rates or engagement in MBC behaviors, so following through on different components of the model and documenting that, that incentivizing that through things like recognition, acknowledgement, maybe even small tokens of appreciation, that can have a facilitative effect. And that goes back to that, concern that providers may have about the sort of punitive use of these measures. So this is distinct from incentivizing or penalizing providers based on the actual patient outcomes. So it's based on the behaviors and using the model, not on the outcomes of the measures. So another identified challenge for organizations and providers trying to implement MBC is selecting measures to use, which I totally understand because there are so many things out there. It can be really difficult to figure out, what to choose, what to use, what's going to best serve, the purpose that you have. So people may lack the knowledge needed to choose appropriate tools or just get generally overwhelmed by all the options that are out there. There have been some efforts to develop consensus recommendations and standards for clinical quality outcomes for eating disorder treatment providers and programs. So this is looking at, more sort of quality improvement kinds of efforts. But these same kinds of measures can be considered within an MBC kind of model as well. So some inconsistencies, of course, still exist, but there has been agreement in terms of some of the broad categories of measures that have been recommended. So, if you're feeling like you need a place to start, here's a place to start with 3 categories. So these include measures assessing core features of the eating disorder illness. The Eating Disorder Examination Questionnaire, or EDEQ, is one of the most frequently suggested measures. It is the one that we use at Within. I've used it a number of places previously. I would imagine many of you are familiar. And it's one I've seen most often reported by other treatment programs as well. I imagine part of that is it's free to use. It's relatively short with 28 items, but it encompasses restrictive eating symptoms, preoccupation and concern with eating, as well as shape and weight concerns. So it's relatively broad in its scope. Also includes items assessing frequency of specific eating disorder behaviors, so binge eating, purging, compulsive exercise, things like that. One of the things that I'm always thinking about in kind of deciding what measure to use, well, there are a number of pieces, but one is the length of the measure. So I mentioned the EDQ being, sort of relatively brief at 28 items. I do not recall where this came from, but I know at some point I learned that on average, it takes about 7.5 seconds to complete a multiple choice question. If anyone has the source for that, let me know, because I've been unable to track it down. It's just been in my brain for many years, both in terms of clinical work and, research, setting up research studies. So I'm always using that as I'm calculating, kind of thinking about, okay, if it takes someone on average 7.5 seconds to complete, one of these items, how many items are there? And then again, depending on how many measures you're intending to include, that can really start to add up. So those are some of the considerations that might go into figuring out what measures to use, thinking about the length. There's a briefer version, a 12-item version of the EDEQ, the short version, that I've seen a lot of people start to adopt, perhaps in part because then, you've cut it down and you have perhaps, more space to add another measure. So I've included several other common measures of eating disorder symptomatology here, all of which have pros and cons in terms of things like, breadth versus depth of symptom assessment, length of the measure, in some cases, cost and access. All of these things can be part of that consideration. Another recommendation is to include a functional assessment or a quality of life measure to look at the impact of the eating disorder across different domains, so such as school and work or relationships. If you're not familiar, the clinical impairment assessment, or CIA, is often used in conjunction with the EDEQ. It's actually meant to be used alongside that. It's a fairly brief option, 16 items, or alternatively, one of several eating disorder specific quality of life measures listed here. We at Within use the EDQOL. Again, a lot of what went into that was just sort of this balancing act. It's relatively brief at 25 items, a little bit longer than the CIA, but it covers some different domains: psychological, physical, cognitive, financial, and school and work. So, felt like it covered the kind of domains that we would want to be able to assess. And lastly, it's recommended to include measures of co-occurring psychiatric symptoms and conditions, with mood, depression, suicidality, and anxiety being considered highest priority. There are numerous measures of these symptoms, of course, with varying pros and cons. At Within, as with many other places, other programs I've encountered, we use the PHQ-9 as a very brief depression symptom measure, includes a suicidality risk item. Many companies and programs use the GAD-7 for anxiety, which is similarly very brief. At Within, we've opted to use the STAI, or State Trait Anxiety Inventory, which is longer, at 40 items, so considerably longer. But again, this is sort of the pros and cons, provides both state and trait anxiety scores, which we found is very helpful to have with our population of patients who are frequently experiencing fluctuating levels of anxiety, working through treatment at higher levels of care. Certainly other measures that could be useful within an MBC model. So these are just some examples, but in terms of eating disorder symptoms, it may make sense to consider more focused measures in addition to or in place of something like the EDQ, depending on your population. So something like the 9-item ARFID screen or binge eating scale that would more adequately assess specific kinds of symptoms. Of course, there are many other areas of functioning that might be of particular interest for your population, or treatment targets that are consistent with, a particular therapeutic approach that you use, such as measures assessing emotion regulation difficulties, perfectionism, interpersonal problems. And then lastly, of course, we know that there are many types of symptoms and concerns that can co-occur with eating disorders beyond mood and anxiety issues. So considering measures that look at trauma, OCD, substance use, to name a few, of course, many options for those kinds of measures as well. So last piece that I want to mention before ending with kind of leaving you with an exercise that you can do for your homework. Considerations for diverse populations. So going back to my earlier points about the art of MBC and how it fits within an evidence-based practice framework, it's of course important to recognize the limitations of these measures, especially in terms of how they may or may not be useful with certain populations, especially populations that are typically marginalized. Of course, this alone, discussion of culturally informed assessment, again, could and should be a full training. But here I just want to make sure to highlight a couple of central points that are important to consider with MBC implementation. So the first is to acknowledge that measurement tools are inherently biased. We know this. They are based on specific samples that were used in the development, standardization, and validation process. We know that is often, white, cisgender, female identified, heterosexual individuals, moderate to high SES backgrounds, right? It's a fairly homogenous group. And this is exactly why we need to think of MBC as perhaps more akin to measurement-informed care or practice that fits within an EBP framework. So that clinical judgment is really essential. So using that along with available information about the patient when interpreting results. Additionally, some studies have been conducted, some, not enough, I will say, to determine the appropriateness of using certain patient-reported outcome measures with different populations to try to establish group-specific cutoffs, norms, and levels, or even create new measures or adaptations of measures. And so depending on the patient, you might find that a group-specific measure or specific values may be more useful than general measures or values that you've established. So I'll use the EDEQ as a quick example. There have been, again, some but limited efforts to develop group-specific cutoffs and norms for the EDEQ. So for instance, there was a study that identified a male clinical cutoff of 1.68 that differed quite a bit from the cutoff of, it varies a little bit, but around 2.8 identified in several studies with all or majority female participants. However, there are rarely replication studies to substantiate these group-specific values. So it makes it really difficult to determine the appropriateness of use, like what should we use here? This one study found this, but of course, no study is perfect. Similarly, there have been a few studies attempting to develop norms for the EDEQ across different populations, so such as gender and sexual identity. But often these studies focus on community rather than clinical populations, which means that they may not have great utility within clinical settings. So again, there is judgment and artistry required to really figure out what measures or values to use to best capture the experience of your patient. I could go on and on about this topic, but I do want to try to leave at least a couple of minutes for questions. So I will just briefly introduce this kind of brainstorming exercise. We won't have time for discussion unless people want to bring things up as part of the question and answer portion that we'll have a couple minutes left at the end. But this is an exercise to just help people start to identify next steps for incorporating or expanding MBC in your own practice or program. I will say there are some absolutely fantastic resources out there for MBC implementation. I'll show you a few links at the end here, including some planning worksheets, guides with important points to consider. Of course, it can still be overwhelming to figure out where to start or where to go, since there are so many pieces to consider with any sort of new initiative or program implementation. I've found it helpful to use a familiar framework for our own work, thinking about the 5 Ws and H kind of model. So as is often the case, these questions may overlap and interact with one another, but framing it in this way can help kind of break down this larger implementation effort into smaller, more manageable pieces and steps and problems to solve. So starting with who, for the question of who, you can consider, which setting or which staff members or which patients are going to participate. And I do want to point out that it's okay, and actually in many cases recommended, to start incrementally, do some MBC piloting if that's more feasible, rather than expecting to completely overhaul and revamp your existing systems and implement, your ideal MBC program all at once. For what this can be focused on, selecting the measures. What are you actually going to include? Where might include consideration of the method of administration, paper, pencil, or online, survey. Also data capture, like where is that information going to go? If you're going to graph it, how, where will that be stored? For when, thinking about when you're going to start, of course, but also then the frequency of measures, the timing of measure completion. Are people going to do them on their own time? Are they going to do them when they come in for appointments? What's that going to look like? The why is, of course, very important, establishing the clinical use of the measures. So what is this going to look like? How is it actually going to happen in your practice? Are they going to be reviewed every therapy session, discussed in team meetings, included in treatment plans? Thinking about organizational goals. So, what does success look like and how are you going to evaluate that? And then lastly, how? So determining the actual procedures and clinical workflow. So how are you going to build this into your existing procedures, or how are you going to shift things so that you can implement MBC? So I will leave it with that. As I said, you can take this as a homework assignment if you would like. Choose one question or area, from this list to kind of get you started, to help narrow your focus. And, from there, starting to outline maybe 2 actionable items to just get the process going, to start initiating that implementation planning. And I'll go ahead and turn it over to any questions that we have for the last couple minutes.
Wonderful. Thank you, Dr. Shepard, for that info. And if anybody wants to put their responses in the chat, feel free to do that as well. We did have some questions roll through, so I'm going to bring those to you now. The first one was, have you seen MBC applied to outpatient levels of care? Are there things that need to be adapted for the clients on the outpatient level of care compared to higher level of care?
Yeah, absolutely. I mean, I've used MBC in a number of different settings that I've worked in, including I was doing it. I had my own very small. I was a full-time academic, had a part-time private practice. And so it was just me, no administrative staff or anything like that. So, some of the examples I gave were literally things that I was thinking about and having to do with, just me and spreadsheets and, whatever I could put together. So, yes, it can definitely be done. And I've seen it be done in all different levels of care. And ultimately, as far as adapting it, it's just really going to depend on, that population and the setting and what treatment looks like. So, in the outpatient level of care, it may look different in terms of frequency. For example, if you have someone who is, at a point where they're not having to come in for, very frequent, sessions, then you may kind of spread out, the frequency of, administering measures. You may think about, different types of measures, of course, to use, depending on severity, depending on co-occurring symptoms, things like that. So absolutely, I've seen it applied, certainly can be applied. And I think, kind of thinking through some of these, I'll pull them back up, but these last points can help with figuring out what it might look like at that level of care versus, a higher level of care.
Wonderful. Thank you. So we had one final question for today, and that is concerns with level of insight/denial. Does that or can that skew measurements?
Yeah, that's a really great question. And of course, it certainly can and does. One of the things that we have looked into and haven't quite implemented yet, because there isn't something fantastic that exists, is a measure that will try to help with that, with at least kind of a validity check, at least, kind of looking at for our eating disorder symptoms, because we know that a lot of that can go along with eating disorders, issues in terms of insight, in terms of denial, in terms of understandably, wanting to minimize symptoms that can all come up. So there are some measures that can be sort of used as a validity check. So that may be an option, although I actually have not really seen that be used in practice yet. So it's something that we're potentially looking into and hope to, if we can figure it out, maybe, do a study and get the information out there. But again, I think this is what I was saying before about this is the same kind of thing that comes up even outside of measurement-based care, right? There are always things that people are bringing in, patients are bringing into session where they're saying one thing and you're seeing something else. And so this is just another piece of information that then you can look at. Okay, you're saying, based on this measure, your symptoms have significantly improved, and yet we have all this other information from, somewhere else that is suggesting otherwise. So how can we try to put that together? So I think that's, again, where it's important to recognize that these measures and these scores are not the be all and end all. They're just a piece of information that we're trying to incorporate into, all the other information that we have.
Wonderful. Thank you, Dr. Shepherd. And it looks like we are about at time. So I want to thank everybody for joining us today and for sharing the space with us. We do have some other really great events within Summit tomorrow and Friday as well. So please feel free to check those out and get registered for those if you're interested. And again, I want to thank Dr. Shepherd for sharing the space with us and giving us so much great insight. And everybody have a good rest of your afternoon. Thank you all again.